Welcome to Champion Health System. Today we're discussing an important topic: understanding heart failure. I'm Jamie Lohwater and I'll be guiding you through the key facts, symptoms and treatment options to help you take control of your heart health.
Yes.
Okay. So for heart failure, I wanted to begin with just the definition of it. So it's a clinical syndrome. It's diagnosed clinically, and it's caused by structural and functional impairments of either systole or diastole. So it's basically an inadequate blood flow to meet the metabolic demands of the body. And this leads to the signs and symptoms of heart failure. There are many different causes of heart failure. So ischemic, non-ischemic, valvular, etc. And you can even further classify it by left or right or by ventricular, high or low output, acute or chronic. It's a very wide range, but typically you will see three widely used systems, and these should be documented in all of the patient charts. So you have the ACC, the NYHA, and then you can also go by the left ventricular ejection fraction. So the ACC staging system, that shows the progression of a chronic disease. So it's the long-term risk stratification from the structural and functional standpoint, regardless of the patient's symptoms at that given time. So it starts from Stage A, patients who are at risk, all the way to Stage D, which is advanced heart failure with very marked interference with daily living. The NYHA is a classification based off of functional status. So it looks at the severity of the disease and the day-to-day living symptoms and changes over time, even if the underlying disease, like the ACC stage, does not change. So here we have 1 to 4, so no limitation at risk or with physical activity. 2, some limitation of physical activity, nothing at risk. 3, marked limitation of physical activity, comfortable at rest, but you still are starting to get symptoms. And then 4 is changes at rest and with exertion. The ejection fraction classification, that's looking at the function of the heart muscle itself. So it's the mechanical pumping of it, and it is separated into mild, moderate, and severe. Mild is HFrEF with the reduced ejection fraction of less than 40. HFrEF is mildly reduced, so that's your moderate between 40 and 49. And then severe, sorry, I had that backwards. Severe is less than 40, preserved is over 50% of ejection fraction. And so categorizing by this, that helps measure the severity, and it's important for informing your treatment approach. So just to compare, ACC is progression of the disease, NYHA is the symptom severity, and the ejection fraction is the functionality of the heart. And together, this sort of gives a comprehensive picture of the patient's heart failure condition, from structural disease to functional impairment day to day and to the pumping ability. So these should all be in your notes at each office visit. So a patient will present with symptoms saying they're very fatigued, they can't walk as far as they used to, chest pain, pressure, tightness, short of breath, things like that. And when you're taking the history, you want to get their functional status, any comorbidities, any sort of hypertension, diabetes, dyslipidemia, and then you want to get signs from the physical exam. So symptoms are what they complain of, signs are what you see. And so the signs are basically, signs and symptoms are both from volume overload generally, and so for signs, you see elevated JVD, rails, hitting edema in the legs. You can have the hepatojugular reflex, abnormal PMI, etc. But that's objective. So when you first work up a heart failure patient, the labs you would start with are going to be a CBC, because anemia can cause high output heart failure. You can also see elevated LFTs from hepatic congestion. A BMP, you want to look at electrolyte abnormalities, so serum sodiums. You want to look at renal function with GFR and creatinine because you can get cardiorenal syndrome from venous congestion. You want to look at the LFTs, like the aminotransferases, for acute changes for hepatic congestion. The albumin and INR are more for chronic cirrhosis changes. Hyper and hypothyroid are reversible causes of heart failure, so you're basically looking for a cause. You can also look for HIV, viral panels, iron, ferritin, other things like that. And then BNP is an initial marker, but it's not useful for treatment or for monitoring like clinical improvement per se in heart failure. The NT-proBNP is splits off of the proBNP into both of these things. And so it's important to note the BNP is not accurate once you add the Entresto because it affects the BNP levels. For initial imaging, it's generally an EKG and an echo. The EKG is non-specific changes. It can help you identify factors contributing to the development of heart failure, so like an arrhythmia. The echo is the most useful initial diagnostic test. It's non-invasive. It can assess the left ventricular ejection fraction, and it can help you evaluate for contributing factors, so like valvular function. Other than that, for progression of heart failure, you would only repeat these tests, or the echo specifically, when it would impact your clinical care. So new symptoms, advancement of heart failure, things like that. Other imaging modalities, you can have MRI, radionuclide, ventriculography, PET scans, CT scans, etc., which would give you additional information. Sometimes you'll see a chest x-ray for patients with dyspnea, looking for pulmonary edema and excluding other potential causes of dyspnea. And then the stress test is a 6-minute walk test, looking for reproducible areas of ischemia, and it's good for differentiating between respiratory versus cardiac causes of dyspnea. And then later on, you can do a right heart cath to help guide therapy for advanced measures. You can also do a biopsy in very select patients where you're suspecting an infiltrative cardiomyopathy like amyloid or giant cell, or coronary revascularization if you are looking to do a stent or a CABG. And so treatment for heart failure is dictated a little bit by what type of heart failure. You always begin with reducing the risk to prevent the clinical syndrome. HFrEF is the most studied type of heart failure. We have the most data in clinical trials. So that's what we will begin with. So for the ACC stages of heart failure, A, B, C, D, A and B is mostly lifestyle modifications. You want to control comorbidities. So class 1 treatments would be control hypertension, optimal control of blood pressure, control of diabetes, CVD, things like that. And you can do scoring to see what your patient's risk of any sort of adverse cardiac event is going to be, their risk of developing heart failure, predicting 10-year risks of CV problems. That's what the heart score, Framingham, ASCVD are, just to help you with their clinical picture and progression. Non-pharmacologic treatments at this stage would be preventing worsening or the syndrome in general. You want to restrict your salt to 2 grams per day. You can also restrict fluid to avoid hyponatremia. You want to recommend a healthy diet, so DASH or Mediterranean. Reducing weight in obese patients reduces workload of the heart. Exercise reduces symptoms and improves functional capacity, and quitting smoking helps alleviate some inflammation and improves vasculature. Moving on to stages C and D. This is when you typically see patients in a cardiology office. They are symptomatic, they're having problems, and so your treatments are going to be 4 main classes of medications. You typically will add each drug sequentially, barring other comorbidities of the patients that would change things. And this allows for identification of any adverse effects or intolerances to the medications. This typically follows the order in which the agents were studied. So the ARNI, sacubitril, valsartan, beta blockers, MRAs, SGLT2s most recently. Again, potassium, blood pressure, heart failure severity can allow for a different sequence of therapies. And you want to make sure that the patients are at the right therapeutic doses. So starting with ACE inhibitors, ARBs, and ARNIs. The ARNI is the first line. You would do the ACE or the ARB if it's not feasible. And if your patient's already on an ACE or an ARB, you would replace it with the ARNI if possible. So the ARNI reduces the pro-BNP and it improves the remodeling, so BNP is not a good marker. For these, you want to make sure you do not use together. Within 36 hours, you need a washout period. And you do not use these in patients with a GFR less than 30, potassium over 5.5, hypotension, or a history of angioedema. ACE inhibitors are the drugs that end in pril, the ARBs are the ones that end in sartan, and the ARNI, cubitril, valsartan, or Entresto. And then these are the target doses slide. So beta blockers are next. They reduce the risk of sudden cardiac death and hospitalization. These are the medications that end in OLOL. Specifically, there are 3 cardiac beta blockers: carvedilol, metoprolol, and bisoprolol. Metoprolol, you want to make sure that you're using succinate specifically, and you do not use these if your patient has bradycardia or heart block, any hypotension, or fatigue, and it's especially useful with the LVEF of 40 or under. MRAs are mineral corticoid receptor antagonists. So they block aldosterone's effect on the heart. They can reduce fluid retention, prevent cardiac remodeling, and improve the heart function. You have 2 of these in this class. You have spironolactone or aldactone, and you have eplerenone or Inspira. So spironolactone can cause more side effects than eplerenone, so it can cause gynecomastia in men. But for both of them, you do not want to use if you have potassium over 5.5, GFR less than 30, or hypotension. So you're going to monitor kidney function, electrolytes, and check the dosing as well. SGLT2 inhibitors are drugs that end in the suffix gliflozin. So it's important to know for these, you can use them for both non-diabetics and diabetics. It's just the class effect for heart failures, dependent of like the sugar levels. It can cause kidney damage, so you don't want to use it in patients with a GFR less than 30. And side effects can include fourniers, so you're more prone to infections, and it can also cause euglycemic DKA. So just something to watch out. So those were class 1 recommendations. These are now class 2A and 2B recommendations. So alternatives to ACE, ARBs, ARNIs. Hydralazine is put with isosorbide dinitrate. It helps reduce afterload if your patient's persistently hypertensive. It also works as an anti-anginal. So you add this combo drug. You wouldn't do it if your patient is hypotensive. It can cause headaches, and these are given 3 times a day. So there's a high pill burden as well. So you have to make sure your patient's compliant. Other medications are ivabradine, verisugat, and digoxin. So ivabradine is a class 2A recommendation. You use it when the patient's heart rate is over 70, despite already being managed with a beta blocker. It can cause hypotension, bradycardia, palpitations, and the mechanism of action is just a SA node modulator. Verisugat is a class 2B recommendation. So despite optimal GDMT, they still have hypertension. You don't want to use it if they have hypotension or low red blood cell counts, because it can decrease it further. And then digoxin is also a class 2B rec. It's an inotrope, generally used for AFib control. It improves symptoms and decreases hospitalizations, but it doesn't improve morbidity or mortality, hence the class 2B recommendation. You have to be aware of digoxin toxicity, especially in renal failure patients, and it has a whole host of other side effects like nausea, vomiting, diarrhea, bradycardia, vision changes, and swelling in the extremities. Diuretic use is only class 1 for symptoms of volume overload. It's not for morbidity and mortality. So initially you will see loop diuretics, furosemide, torsemide, bumetanide, low sodium diets. You just have to be careful with loop diuretics. You're at an increased risk of increased risk of arrhythmias. If you get hypokalemia, it can cause metabolic alkalosis and ototoxicity, so like tinnitus, ringing in the ears. Thiazide diuretics, so hydrochlorothiazide, HCTC, or chlorthalidone, are an addition for patients who do not respond to a moderate or high dose loop diuretics, and it can help minimize electrolyte abnormalities. So just further medication treatments that you can do. There's been no proven benefits for hormone therapies unless there's a specific replacement that's needed due to a specific deficiency. There's no data on supplements to improve heart failure symptoms or outcomes. There's some data to support the use of omega-3 fatty acids, but the one that we do have data on is IV iron use if they're iron depleted. So you would check iron levels and transferrin saturation. So this one does have a mortality benefit. Iron deficiency also leads to very similar symptoms to heart failure, like fatigue, dyspnea, reduced exercise intolerance, muscle weakness. So iron is useful to check. So we talked about HFrEF medical treatments because of the clinical trials. HFrEF, so the mildly reduced 41 to 49% ejection fraction, it appears to respond to medical therapies very similar to HFrEF patients, but there are no prospective randomized control trials for them. So you treat very similarly to HFrEF patients, and you would repeat the ejection fraction just to determine the trajectory of their disease progress. For HFpEF, you just want to adjust the medications, titrate to obtain like the target blood pressure goals. It's a very heterogeneous disorder, multiple comorbidities. It's very broad. So we tend to use the same medication options as with HFrEF. There are certain drugs that you want to avoid in heart failure for various mechanisms. They can cause sodium and water retention, cardiotoxicity, drug interactions, absorption, and clearance. So there are NSAIDs, antiarrhythmics, calcium channel blockers, and TZDs. Starting with NSAIDs, it can cause sodium retention and peripheral vasoconstriction. It also blunts the response to diuretics and ACE inhibitors. So aspirin, naproxen, ibuprofen, things like that. Just monitor medication lists when patients come in, and you can even ask about some of these. For antiarrhythmics and calcium channel blockers, you're going to have a negative inotropy effect and increase risk of cardiac death for the class 1 and class 3 antiarrhythmic agents. So class 1, quinidine, procainamide, lidocaine, flecainide. Class 3, dronedarone and sotalol. And then calcium channel blockers. So they can interact with the beta blockers, which are class 1 treatment recommendations for heart failure patients. And that will increase your risk of heart blocks, bradycardias. There is no benefit for dihydropyridine calcium channel blockers. Those are more the vasodilators. They decrease the systemic vascular resistance with minimal effects on heart contractility. The non-dihydropyridine, so cardizem and verapamil, they affect the SA and AV node, and so that actually can cause harm in patients with heart failure. The TZDs are the ones that end in glitazones. They can cause sodium retention and fluid retention and can worsen clinical symptoms, so you want to avoid those if you can. Moving on to advanced heart failure treatment, if you have tried all other medication options and the patient is still progressing, you can, for patients with ischemic heart disease, you can use an automated implantable cardioverter defibrillator, an AICD or ICD. It's the primary prevention of sudden cardiac death to prevent mortality in these patients. It's in the right ventricle and or the right atrium, and it's capable of delivering shocks for tachyarrhythmias. It's also capable of pacing in bradyarrhythmias. CRTs are cardiac resync therapy devices, so it is capable of pacing both the left and the right ventricles if there's a dyssynchrony, so inefficient pumping between the two ventricles, and it can be coupled to a defibrillator. And this is what they look like, showing which chambers of the heart that they're in. And on a chest x-ray, you can see that defibrillators will have coils in their respective chambers. So on the middle and the right, you can see a thicker loop of wire, and that's how you know it would be a defibrillator. versus an alternative pacemaker. Other options, if they fail device therapy as well, you can do revascularization, so a PCI or a CABG. You can fix valvular problems if that's a contributing cause to the heart failure, and you can use inotropes as well. So for bypass, CABG, coronary artery bypass grafting, or PCI, percutaneous coronary intervention, it depends on the severity and the complexity of the CAD, comorbidities, and prognosis. So you use PCI for single or double vessel disease without left domain involvement, and CABG for left domain involvement or three vessel disease and refractory angina or post-PCI failure. For valvular surgeries, it can be transcatheter surgical approaches to prevent deterioration. The choice depends on the effective valve, severity, and comorbidities. You'll see the abbreviation TAVR and SAVR for the aortic valve specifically. Typically, you would do the surgical approach for younger patients, low-risk patients, and a transcatheter one for severe left ventricular dysfunction. And then inotropes will enhance the contractility to improve cardiac output and perfusion. It helps with symptom relief, but it more plays a palliative role as a bridge to definitive treatment, waiting for long-term things like a heart transplant. It will increase mortality with long-term use. That's why inotropes are more towards the later lines of treatment. And these are the inotropes that you typically see. They're at risk for a catheter-related infection because these are IV. So dopamine, dobutamine, milrinone, and then epi and norepi with their infusion rates are on the screen. At the very end, you won't see this often. This will be a very advanced heart failure clinic. You can do mechanical circulatory support, MCS, with an LVAD, a left ventricular assist device. So these are advanced HFrEF patients with stage D heart failure and significant symptoms. The most common devices are going to be like the HeartMate 2 or 3 now. And there's also another brand called the HeartWare. And so this is what it looks like on imaging. It's really just for when you're awaiting a heart transplant and you've exhausted all other options. And if they fail that, you would be talking about palliative care. So overall, for heart failure, it's a disease progression, severity, and function. It's a clinical diagnosis. You would classify it with ACC, NYHA, and the ejection fraction. Your first-line medications, barring comorbidities and other patient-specific things, would be the ARNI, beta blocker, MRA like spironolactone, or eplerenone, and your SGLT2 inhibitors. You want to avoid certain medications like NSAIDs, antiarrhythmics, non-dihydropteridine calcium channel blockers, and TZDs. And then at the very end, you can do more advanced interventions. Does anybody have any questions?
Yeah, it's a great presentation, nicely put together.
Thank you.
Okay.
Yeah, no questions here, but it was great. Very useful.
Mm-hmm.
So I think the main thing for calcium channel blockers is when most patients come when they have a heart failure, just make sure that we are not starting the patient on verapamil or diltiazem, or if the patient's on it, change to amlodipine, because that's the one calcium channel blocker that we could use. That's a nice point that you put. But for diabetes, the other thing is, most people we don't normally look into all the diabetic medications. So make sure that, can you go back to the last slide, Jamie, which is a nice summary that you put?
Sure. Oh, can you see that?
Yeah, it's coming. Go one slide back. It says questions. Yeah, this is the one. Yeah, I think everyone should memorize this. This is a great slide. This is what you need to know. Every patient that we need to understand that we have to do when they have a heart failure, we should talk about first thing is that AHA heart failure class A B C D, then the functional class. So these two has to be in your notes, which is very important. Okay, I'll let other people ask questions.
I have a quick question. Thank you for the lecture. It was very good. Even for a foot and ankle surgical perspective here, I'm curious. So we see these patients coming in and out of our clinics, and one question is, what is the mortality rate, sort of long and short term, of the different levels of risk with this group? And that would be the first important question.
So I don't actually know the mortality risk off the top of my head. I would just know the like what screening guidelines you could do, sort of like ASCVD is for 10-year cardiac events. I don't know the numbers off the top of my head, though.
All right, the reason I ask is, so, are these patients that reconstructing something in their foot and ankle that's at risk to them for ulcerating or an infection has some benefit in the long run for these folks? At least from a surgical perspective, on my end, it would, given if they were going to live long term. So number one, does that kind of thing make sense, or are we just really doing palliative care on a lot of these folks? What are your thoughts on that?
So you would just have to, that's why surgeries aren't like primary interventions. It's more once they've failed medical therapies, you would go to devices and then some more surgical interventions, and transplant would be the last option just because of the risks and benefits. It's sort of all other options are exhausted.
And can they be medicated for discomfort? It looks like all the anti-inflammatories are out of the picture. What do you medicate them with for, let's say, arthritic or neuropathic pain?
So, Dr. Leisman, you actually asked a very good question about these patients. How are they? What is their longevity? Most patients, most clinicians don't know that end-stage heart failure is almost same or worse mortality when compared with many cancers. So these patients have to be treated aggressively. Yes, you need to avoid NSAIDs, but you might have to think about the main reason they're talking about NSAIDs, it actually has a sodium retention.
Yes.
When they have a sodium retention, they go into heart failure. So you could use them sparingly if it is needed, or you could try like Tylenol or non-NSAID pain medications.
So tramadol, gabapentin, the gabapentinoids, that type of group.
Yeah. So yeah, whichever is not an NSAID, I will try. And also, the other question you are asking is, yes, do they need to get fixed? Yeah, it is better to get them fixed because they already are, having a lot of burden because of the heart failure. So it's better to get them more mobile and, at least get them more functional.
Mm-hmm. Okay, that helps. Thank you.
Okay. Yeah. Thank you, Jamie. It was, I think you did a good presentation, and, it is actually, very well done presentation.
Heart health is in your hands. If you or a loved one is experiencing heart failure symptoms, don't wait. Seek expert care. Champion Health System is here for you. Heart health is in your hands. If you or a loved one is experiencing heart